We're going to be talking about cardiovascular screening. In fact, I almost feel more nervous about this session than I felt about watching that game last night, because the more people I talk to amongst you, the more I realise that this is a vexed issue in South Africa. Actually, in that respect, it's no different to anywhere else in the world, and that kind of leads into the story of why I'm the person who's standing here talking about it this morning. This has been recognised as a big issue for recreational divers, particularly, actually more than occupational divers, because they're a harder group to manage. And several years ago, the Dan Group put on a workshop which they called somewhat, I don't know what the right word is, but they called it their Dan Fatality Workshop. And it was a workshop to address the issues of deaths amongst recreational divers. And one of, if not the biggest issue that fell out of that was the fact that it's cardiac events that seem responsible for a large number of diving deaths, particularly amongst recreational divers. I'll talk about that in a second. And so this workshop was put together to come up with strategies for trying to reduce diving deaths. Obviously, that's one of the things that Dan's all about. And as part of that, Fred Beauvais, who I've acknowledged here, and I ran a session on the cardiac side of things. Fred is arguably the world's most prominent diving cardiologist. He's previous president. In fact, at the time we did this, he was the president of the American College of Cardiology. So he's a very eminent guy and written extensively on this. Not to say that I agree with everything he's written, but he certainly is very knowledgeable. It was great to work with Fred on this, and we ended up producing that paper that you've got in front of you. Now, the reason I've given you the paper is not because I think it's some kind of stellar document that answers all the questions we need answered. It's because I'm going to be showing you some of the tables from it. And you know what happens when you put up a table from a paper? You can't read it, so I just want you to have it in front of you so you can read it. In that respect, I do this, of all the talks I'm giving this week, I feel this is kind of like the most functional one. I'm just presenting to you what we did at that workshop. It feels to me like it's going to be very boring, but I do accept that it's an important topic and worth giving a bit of time to. So when I'm finished with presenting you where we went with that workshop, and I emphasise that it was mainly about recreational divers, I will inject into this presentation a few comments about where I think occupational diving paradigms can be a little bit different. Then we'll have a discussion about it. That's how it's going to go. Is that pretty much? Yeah. Okay. All right. So the way we'll go is we'll talk about scuba deaths and their causes, a system for evaluating the health of diver candidates. Now, that's just a recap on what actually happens out there in the real world. We're just going to recap on that, just so that we're all clear about the systems that are currently used in the world for recreational diver evaluations. As I say, I'll drop into occupational diving medicine where I think it's necessary. We'll talk about screening for cardiac problems using a questionnaire. We'll talk about we'll try and define which problems that might fall out of such a process you would absolutely say you can't dive, and then which factors that might also fall out, which risk factors that might fall out of a screening questionnaire that you would want to pick up on and use to indicate further testing in the candidate. And then perhaps the most controversial thing of all, we'll talk a little bit about if you want to screen for ischemic heart disease, what screens are you going to use? And then I also know that who should be tested for a PFO is an issue that has caused you some anxiety as it has everyone else. So we'll make some comments about that as well. So a little bit of background that led to the dedication of a significant amount of time on this issue at the Dan Fatality Workshop. This paper came out in 2008, and it was an attempt to define the death rate amongst recreational divers. It's published by the Dan Group, and I actually think this was a really smart way to do this. You know, the problem with all of these sorts of studies is always the denominator. We know how many deaths there are, but we don't have a denominator, so it's hard to calculate death rates. And what they did, and it's really smart, and in fact it's fairly obvious too, but no one had ever done it before. They used the population of insured Dan members as their denominator. And if you think about it, it's a reasonable thing to do, because why would you insure yourself for diving injury if you didn't dive? Right? So you kind of define yourself as a diver by taking out that insurance. So that's how they did it. And what they found was that the annual diving-related death rate amongst insured Dan members in that period there was 16 per 100,000 participants, which that was the first time we had a hard number that you could really hang your hat on. So 16 per 100,000. For jogging, I think it's 13 per 100,000. It's it's not either particularly high or particularly low in relation to other activities. Having said that, I think I showed you some data yesterday, which is softer, much softer data, which suggests that rebreather divers within the recreational diving world have a rate that's about 10 times that high. So, if you substratify divers, it looks a bit different. But anyway, that's the death rate amongst divers. And then the other thing that they did, not long after that, this paper came out in UHM, and it was an analysis of almost 1,000 deaths where they had really good data about the death, information, an autopsy, recovery of equipment, those kind of things. So they were selective about these deaths over a period just longer than 10 years. And as you are all aware, what usually happens in a diving death is the coroner will attribute it to drowning. But as we all know, drowning is always just the final common pathway in a process that's been kicked off by something else. So what the Dan guys did was they created a hierarchy of causative events. So they identified a trigger, the disabling agent, the disabling injury, and the final cause of death, which in fact in diving is usually drowning. But if that's all you focus on, then you miss out on figuring out what led to the drowning. And to cut a long story short, a cardiac incident was the disabling injury in 26% of these deaths. So that's quite a high proportion. There was convincing evidence that a cardiac incident was the disabling injury in 26% of cases. And pre-existing cardiac disease and age were not surprisingly strongly associated with these cardiac incidents. And that raises an obvious question, does it not? And bear in mind at this point I am talking about recreational diving. The question is, are our systems for assessing and monitoring the health of diver candidates and divers inadequate in respect to detecting pre-existing cardiac disease? I mean, the inevitable conclusion or answer to that question would be, well, yeah, because 26% of the deaths that occur are due to that, and we're not preventing that. So what's going wrong? And that's where the workshop was going. So let's just recap on how the health of recreational diving candidates is assessed. So this very simple paradigm describes what I think happens in most places in the world. So someone wants to become a diver, and the first thing that they will do in the medical side of things is they'll fill out a questionnaire, a screening questionnaire. And in many cases, in many places, that's all they do, potentially. What's the situation here? Same. Okay. So there's a screening questionnaire. Okay, yeah. So some training organisations will voluntarily impose a standard where they have to have a medical. Yeah. And that's actually true in other places in the world as well. But they may or may not have a doctor consultation, is what we're talking about. So in many places, including the very litigious environment of the United States and now Australia, actually, they just fill out a questionnaire, potentially. And if there's no positive finding on that questionnaire, they just go and do their course. And perhaps most importantly, They could do that at the age of 30 and continue diving to the age of 70 and never interface with a diving medical person ever again, potentially. So in recreational diving, this is where we have an advantage. In occupational diving, we have compulsory ongoing health surveillance. But in recreational diving, there's no ongoing health surveillance. Of course, if there's a positive finding on the questionnaire, they can't do the course. They have to go and see a doctor who will examine them, take a more in-depth history, perhaps do some investigations, and that could result in confirmation of the fact that they're unfit to dive, or if the doctor can convince themselves that the positive finding on the questionnaire is nothing to worry about, they might end up going diving. And that's kind of how that's the recreational diving paradigm. Now, if we apply that to the issue of cardiac problems, then we can translate that exact same paradigm into something that looks like this. And this figure appears in that paper, but you don't need the paper to read it because it's a figure. We'll get to the tables later. So with respect to cardiac problems, a diver candidate completes the questionnaire, and if there's no important positives, they'll go and train, and they may never have surveillance again. And that actually, just that up there, in fact, is probably the biggest problem. Because, of course, everyone's healthy when they're 30. But what happens by the time they're 50 or 60? And they're not having health surveillance for their diving. If they actually have symptoms of cardiovascular disease or established diagnoses that fall into particular categories, and we'll talk about that, they wouldn't be allowed to dive. And then there's another group of people who might not have symptoms or established diagnoses, but they've got risk factors that are revealed by the questionnaire, and those are the ones that we might want to investigate further. And if those investigations are positive, they wouldn't be allowed to dive. If they're negative, we would allow diving. And this line here just indicates that not all of these diagnoses are factors that would make you immutably unfit to dive. Some things can be treated, and if they're treated successfully, you might end up being able to dive. And in fact, a classic example of that would be someone who says, yes, I get angina, I get chest pain on exertion, goes and has an angiogram and has a couple of stents put in. 6 months later, they're off their clopidogrel, they have an exercise test and it's negative and their functional capacity is good. There was a general consensus at that workshop that a candidate like that probably can participate in recreational diving. They've had their problem fixed. And so long as they have a negative stress test after that intervention, that would probably be fine. That's just an example of someone who might go down that path. So this diagram, this paradigm, begs a number of questions. And the first one, and these are the questions that we addressed at the workshop and that are addressed in that paper. So what questions should be on the screening questionnaire to try and detect cardiac disease? What questions are important? Because let's be clear about this, and I'm no expert in this. I'm no expert in designing questionnaires, but I'm sure you'll all appreciate the strength of a screening questionnaire is the questions. It's got to be right. So the better you can get that, the more likely it is to be successful. So what questions? And then which symptoms or diagnoses that the candidate might report as a result of the answers to those questions are the ones where you would say, no, sorry, you can't run a bath deeper than 6 inches, let alone go diving. And then the next question is, which risk factors would we want to investigate? What things they might reveal on their questionnaire response would say, okay, well, you can't go diving until we've investigated these. And then the next question is, what investigations would you use? And then finally, you might talk about what surveillance. That's an issue we might not touch on today, because these are the things that you're grappling with, in particular this one. We'll come back to that. So out of this workshop came this paper that you've all got a copy of that Fred and I wrote. And we went through this, we sequentially went through those questions that I introduced before. And we can do this pretty quickly because we'll come back and discuss it later on. So the first one, I said the first thing was, what are the questions that you should have on your health surveillance question or your questionnaire to detect cardiac disease? And the first thing we did was to ask ourselves, well, what do we ask now? And so we got the PADI / RSTC, Recreational Scuba Diving Training Council, standard questionnaire. And do they use this one in South Africa? I bet they do. It's kind of international. Everybody uses this questionnaire. So this is the current questionnaire, and the boxes show you haven't got this. You don't have a copy of this. And because you don't have a copy of this, I've made the boxes bigger on this slide. Those are the questions on the current PADI questionnaire that you could construe as pertaining to cardiac disease, potentially. Some of them are ambiguous, so blackouts or fainting aren't always cardiac disease, but they're potentially a manifestation of cardiac disease. The others are somewhat more specific. So I'm not going to read them out. Those are the current questions. And then we said, well, the obvious thing to ask about that is, are there any questions missing? And for that we went to the American Heart Association pre-participation questionnaire for athletic activity. Because as you can imagine, in the United States, they're quite keen to make sure they don't have kids dropping dead when they do physical education at school. So they have these questionnaires that the American Heart Association designed. And we reconciled these questionnaires on the diving screen against the AHA ones to see if there were anything missing. And so that questionnaire is detailed in this publication, Circulation 2007 American Heart, and Pamela Douglas, who I'm going to quote later, is one of the authors on this paper. But these were the things, and this is in your paper. So this is table 1 from that paper you've got. If you can't read this, these were the things that were missing from the PADI questionnaire, and still are actually. We have recommended to them that they include them. That these are the things that were missing from that questionnaire that the American Heart had recommended. So again, I won't read them out. When we debated whether these should go into the PADI questionnaire, the RSTC questionnaire, a couple of points came out of that. One was to say that this should be modified to exclude murmurs that had been previously known, investigated and designated benign, because there are quite a few people who have those, and that would be a complete waste of time and money to re-investigate a murmur like that. And the other point that came out, which I actually thought was a good and insightful one, and it was great to have people who were teaching divers a lot in the room, was to change the wording of this question, to include these points, but to change the wording. Because the point that was made was that when divers are given this questionnaire to fill out, what they're told is, if you're not certain, tick yes. You know, because just in case. So if you're not certain, tick yes. And so if you look at this questionnaire at face value, do you or a close relative suffer from hypertrophic or dilated cardiomyopathy, long QT syndrome, other ion channelopathies? You can imagine the average diver reading that, they go, I don't even know what they are, let alone whether I suffer from them or a relative does. So if I'm not certain, I'll tick yes. So we changed the wording of the questionnaire to be, have you or a close relative ever been diagnosed with? And what that meant was, well, if they haven't been diagnosed with it, then I can tick no. And so it makes it a clearer question. And so out of that, and again, you probably can't read all this, but it's in your paper, we proposed a modified, revised screening question. These are just the questions for cardiac disease. Now, look, so this is point number 1 about occupational versus recreational. I don't know what screening questionnaire you use for your occupational medicals, but you could consider looking at this list and saying, if we're missing anything off this list, we could put it in there. Because this is the list that we think, and we'll come back and discuss this. This is going to be one of the discussion points. We'll come back and discuss this. You may think that there are some things on here that are still missing from here, and that's fine. But this is what we think is, it's a combination of the RSTC questions and the AHA questions worded in a way that we think is diver friendly, and so you might choose to have a look at that and modify your own questionnaire accordingly. The next part was, well, what symptoms or diagnoses would result in us going, no, you can't dive, and you probably can't dive forever, or unless you have it fixed. And so this was the table of those diagnoses that we came up with. Now, again, we'll come back and discuss this, but these are the proposed automatic initial contraindications, and you've got this table in your paper if you can't read it from here. And the point I made before is that some of these conditions are actually amenable to treatment and re-evaluation. Some aren't, of course. So long QT syndrome, that's kind of it, really. You can't do anything about that. I mean, well, you can medicate patients who have it to try and prevent problems, but you can't be sure about it. Similarly, a dilated or obstructive cardiomyopathy, but one that is potentially treatable is coronary artery disease, as I pointed out before. So those are the things where you'd go, no, you can't dive, and really, until you've been to whatever specialty will deal with it, usually cardiology or cardiac surgery, and if it can be fixed, then fine. Are there any cardiologists here, by the way? No, okay. All right, good. I don't really mean that. It would be great to have some cardiology input into this, some local cardiology input. But yeah, these are those. You can see the point of this list. This is kind of a full stop, and really your diving career can't progress any further. And you may feel there are things missing off this too. You may, and that's fine. We can discuss it. It's a point for discussion. And then we get into the slightly murkier area of what symptoms or what risk factors would indicate further investigation. And actually it's murky, but it's reasonably easy to answer where we got to. We generally agreed that all of the diagnoses and risk factors listed in Table 2 are likely to lead to investigation, although high blood pressure and the medication question need to be interpreted in context. So what I mean by that is not everybody who's taking medication, or not everybody who has, for example, adequately treated high blood pressure would need to go on to further investigation. But this is back to the table that you've got. You would want to investigate someone who's positive on that question. You certainly would someone who says they've had a heart attack, heart surgery, or blood vessel surgery. Chest pain, unexplained shortness of breath on exercise is one of the ones that would stop you from diving, and you'd probably want to refer them on for investigation as well. Similarly, inappropriately low exercise capacity of presumed cardiac origin is one of the things that would stop you from diving, plus you'd probably refer them. The family history questionnaire would want to be investigated. The heart valve disease question would be investigated. Well, the murmur would be investigated, except if you've got a murmur that's been investigated before, as I pointed out. Most of these are full stops, and you might want to send them on for investigation. Long QT, Marfan's, a heart rhythm problem that limits exercise. It may well be that it's all been sorted out, but they're still unfit for diving. And the prescription medicine question, well, that needs to be interpreted in context along with the blood pressure question. So that was an attempt to identify the people that you might want to investigate further based on the history, even though they don't have any obvious symptoms of cardiac disease. And then the issue of what investigations you would do. And I think this is the one that has troubled you the most, or at least the context in which to do investigations, and then which ones you would use. So we'll spend a little bit of time on this. To some extent, it depends. The choice of investigation. It was interesting having these non-diving cardiologists, because they were all at the workshop they were quite perplexed that we would even consider there'd be an issue with ischemic heart disease in young people. You know, look, talking about stress testing 35-year-olds or 30-year-olds. I mean, they were going, well, that's not what kills 30 and 35-year-olds. They have a separate set of problems. So their point was that young participants, so arbitrarily less than 35, sorry about everyone who's over 35 in here, young participants in strenuous activity are more likely to die from inherited structural heart disease than ischemic heart disease. And if you're investigating for that, you don't want to use tests for ischemic heart disease. The things that where the money is with those kind of people is a resting ECG, looking for things like Wolff-Parkinson-White or long QT, and echocardiography. If you're going to investigate those kind of people, then those are the investigations you'd do, not a stress test or some other investigation for ischemic heart disease. Obviously, older candidates are more likely to have ischemic heart disease, and in that setting, tests for ischemic heart disease would be more appropriate. Now, this is where I just deviate to one side from recreational diving for a moment, because in occupational medicine we see them, right? It's not just a list of questions that decide whether they need to be seen or whether they need investigations or not. We actually see them. We can mandate certain things. So, for example, in occupational medicine, we have the opportunity to apply the predictive algorithms for ischemic heart disease because we can measure things that can't be measured on a questionnaire, like we can definitely take a blood pressure, so we can measure their systolic blood pressure and we can get a cholesterol measured. And those are the things, along with a couple of other items of history, that you need to plug into predictive algorithms, and there's a number of them. So you can go online, for example, and find things like this. So this is a predictive algorithm that comes from a website put up by the New Zealand Ministry of Health, but you'll find things like this. Probably South Africa has a similar, based on the Framingham risk score. So these are algorithms where you need to know whether the patient's a diabetic, a smoker, or a non-smoker. So this is diabetic, non-diabetic. You need to know their systolic blood pressure, you need to know their cholesterol, their total cholesterol HDL ratio, and you need to know their age. And with all that information, you can predict their 5-year risk of developing symptomatic or fatal coronary artery disease, and those colour codes correspond to these different risk categories. So you can plug all that information into a risk predictor, and then you can come up with these numbers, and that allows you to make more informed choices. It allows you to refine your choice about whether to investigate or not based on fairly objective databases that are huge. As you know, the Framingham risk score is based on the Framingham study and other data as well. And this is what Pamela Douglas had to say about how you would interpret those data at the Dan Fatality workshop. Pamela Douglas is the professor of cardiology at Duke. She's a very, very knowledgeable woman. And so this is what she said, and I'm going to read it out because I hate doing that, but I'm going to. So preventative interventions are recommended based on these estimates of 10-year risk or 5-year risk in the case of the predictor I just showed you. Individuals classified as having a low 10-year risk defined as an event rate of less than 10% should be treated with reassurance, and further risk assessments should not be performed. So that would be a hard reason if someone fell into that category in your occupational medicine clinic for not investigating them any further. Individuals estimated to be at high risk, defined as a 10-year risk greater than 20%, should be treated with aggressive risk factor modification to secondary prevention goals. It's less clear, however, how individuals classified as having an intermediate 10-year risk event rate of 10 to 20% should be treated. The AHA recommendations suggest considering referral for further tests such as atherosclerosis imaging for reclassification into either high or low risk group. So what that's basically saying is that anyone who falls into a low risk category, 10%, you can reassure them and send them on their way, but anyone above that probably should be investigated. And there's one way. I mean, my understanding from talking to people like Franz is what we've all been grappling with in the occupational medicine world is how to select the people who we need to push further into the investigation pathway, and what our responsibilities are in that regard. And I'll come back to that in a moment. But this is one way, it's one option, using a risk predictor and deciding on the course of action based on the category of risk that they fall into. This is one way of approaching that problem in the occupational medicine setting, where you have all the information to use these risk predictors. So what tests for ischemic heart disease are available? Well, there's a list here: stress ECG, echo, myocardial. I didn't know this was a gymnasium. It sounds like a Zumba class or something. Anyway, a myocardial perfusion scan, a coronary artery calcium score, carotid intima media thickness, CT angiograms, and traditional angiograms. So I think you've probably heard of all of these. Some of them are readily available, some of them not so, some of them are cheap, some of them not so, and they have different sensitivities and specificities in different settings. And I think this is one of Pamela Douglas's slides, and I think it's a great way of conceptualizing where these tests have their strengths and weaknesses. So essentially, this represents the progression of coronary artery disease over time. And so you have essentially normal coronary arteries through to obstructive disease with coronary events because of plaque rupture. And along the bottom here, you have the different tests that appear useful at the different stages of disease. So if your aim is to predict who might have coronary disease moving into the future, but they've got normal coronaries, then it's the risk factor burden, it's the history that you're interested in. If you are trying to detect disease or predict disease at the earliest stage, then you might choose the carotid intima medial thickening test, because that seems to be the thing that detects or predicts coronary disease at its earliest stage. If you're interested in detecting early plaque formation, a CT angiogram, or an angiogram, but a CT angiogram is easier to do and less invasive, would be your choice. And it's not until you actually start to get plaque formation that tests like coronary artery calcification investigations start to become useful. And the interesting thing is that exercise tolerance tests are really not going to tell you anything until you get to this stage here, which is why they have useless sensitivity if you do exercise tolerance tests people who are down here. They're not going to be positive. Exercise tolerance tests become positive when you have obstructive disease. That's why they have very low insensitivity in non-symptomatic people. If you're down here and you do an exercise tolerance test, you may have early coronary disease, but your test's not going to be positive. And so your choice of test depends a lot on what you're trying to achieve. So, and it's kind of going back to a conversation I just had with Franz this morning. If what you want to know is whether someone's going to die in the next year during a dive, an exercise tolerance test isn't a bad choice, because it's going to tell you if they look like this. But if what you want to know is whether someone is going to develop significant coronary artery disease over the next 10 years, and they haven't got it now and they're asymptomatic, then it's probably useless, and you need to be going for something like these things down here, if you're investigating for that purpose. So one of the things we need to think about as a group is, as occupational physicians, what is our role? Are we trying to make sure that the diver's not going to die over the next year during a dive, or are we trying to take a more holistic view of their health, projecting it into the future and managing them in a way similar to what a family practitioner might? And those are philosophical issues that I can't answer. It's something that we need to think about as a group, because the choice of your investigation is going to depend a lot on that. My own sense it doesn't bother me, but I don't know what it is.
I've spoken to the lady. Maybe a Tuesday night upstairs.
Oh, okay. They probably turned up the volume because of me. It's fine. So, do you see the point I'm trying to make here? And I think this illustrates, we've often been told over the years, doing exercise tolerance tests in asymptomatic people has incredibly low sensitivity. And I think, my personal belief is that this slide tells you exactly why. Because it's not going to detect these people. It's a test designed to pick up obstructive disease. Now, when we had this debate at the fatality workshop, the choice was between coronary artery calcium scores and exercise tolerance tests. Because this is slightly more sensitive for milder disease. Can I just make another point? Why would I not do CT angiogram on a recreational diving candidate who had risk factors? The answer is, if it came back and it said mild diffuse disease and they had a reasonable functional capacity, am I going to stop that person from diving? I'm not, am I? I'm going to let them dive. I'll probably talk to them about risk factor modification and ongoing health surveillance, but what I'm really interested in at that point in time is whether they're at risk of a myocardial event when they go diving, which is what kills people. So I'd probably choose one of these investigations here. That's what I would choose for that reason. Anyway, we had this debate about these two modalities because they're both sort of in that zone. And there's no question that coronary artery calcium scores are more sensitive if they're asymptomatic. Who has ever ordered a coronary artery calcium score? A few of you, yeah. Who's ordered a stress test? A lot of us, yeah. Kind of says everything. The problem with this is it's costly, it's not always available. It does involve a small amount of radiation exposure, so 1 to 2 millisieverts. It's about a tenth of what a CT angiogram involves, which is 20 millisieverts of radiation. The problem with coronary artery calcium scores is that it's difficult to interpret the score when you're trying to decide on a binary outcome. Can dive or can't dive. It's actually a good score for sitting down in a family practitioner's surgery and having a conversation about where your life's got to go. It's good for that, but it's hard to interpret in terms of you can dive or you can't dive. And you can see where I'm going with this. Now, an exercise tolerance test is insensitive if you're asymptomatic, but it's cheap, it's widely available, it doesn't involve radiation, and one of the beauties of it is that the implications of a positive test are obvious. There's no difficulty in deciding dive or can't dive if there's a positive exercise tolerance test. They can't dive if it's positive. End of story. Until they either, well, they can't dive until it becomes negative through some kind of intervention. And the other thing that we liked about the exercise tolerance test is it gives you some sense of the functional capacity, which is important. One of the things that got debated at this conference, which I raise here because it often comes up in the literature, is what is an adequate functional capacity for diving? And Fred, in the past, has been one of the advocates for saying a diver should have a peak capacity of 12 METs, 12 metabolic equivalents, so that's 12 times the energy output that you're all expending here. The point that came out at the conference, and Neil Pollock had some beautiful data to illustrate this, was that when you do test a group of divers for peak functional capacity, many of them can't make 12 METs. In fact, about 50%. So you'd rub out a large portion of your population if you insisted on a 12 MET exercise capacity. So although it might remain part of a target for certain people of certain age groups in a Bruce protocol for stress testing, we agreed, we actually got consensus, including Fred, that it's not a realistic standard for diving, and we came to a consensus that a more pragmatic standard or target for a diver would be a sustained capacity for, say, 20 or 30 minutes of 6 METs, which is slightly more than swimming around. Spotted at CJ, thank you. So based on that discussion, I want to ask you, or pose it's like a rhetorical question. Well, I'm going to answer it with my opinion. In an occupational diving medical, should a young candidate, less than 45, who's negative on all the screening questions, undergo a baseline stress test? And my answer, I'm sorry, and I know this might be controversial, I'm probably going to say a few controversial things today, because I think this gets done sometimes here, a baseline stress ECG. Yeah, okay, well, I think that's a complete waste of time and resources. Based on what I've told you, I just think that's just crazy. It serves no purpose, other than assessing their functional capacity. But in most occupational candidates, it's not necessary to do a stress test. We can come back to that. We can come back to that. But I don't think that that is necessary, based on what I've said today. Young, no positive responses on the questionnaire. A baseline stress test. If you want to do a baseline anything, do a carotid intermedia thickness. Do that. That will predict their future risk of cardiac disease, but a stress test will not. Anyway. So in the last 10 minutes of this phase of the presentation, I'll just quickly talk about this issue. Who should be tested for a PFO? And the nice thing is that hot off the press is a joint position statement between us and the UK Sports Diving Medical Committee that we generated at the last SPUMS meeting, the SPUMS meeting before last, where we had Peter Wilmshurst and Mark Turner. Of course, Peter Wilmshurst, very well-known British cardiologist who has had a lot to do with investigating the issue of PFO and diving. Myself and David Smart were also involved in generating this consensus. And this was one of our clear statements, and I think we can all take this away and be happy about it. This is published in SPUMS, by the way. Sorry, not SPUMS, we don't call it that, DHM. In June this year, but routine screening for persistent foramen ovale or patent foramen ovale, PFO, at the time of a diving medical fitness assessment is not indicated. Routine screening. It's not indicated. And that's a very important point. I mean, can you imagine what would happen to the diving industry if every PADI diving candidate had to go and have a bubble contrast echo before they did their diving course? That'd be it. So who do you test? And this was the statement we came up with. So consideration should be given to investigating under the following circumstances. So decompression illness with, it's very important, 4 specific manifestations: cerebral, spinal, vestibular cochlear, or cutaneous. Not pain, musculoskeletal pain, not patchy paresthesias or tingling. In fact, not anything else. Those are the 4 forms of decompression illness that have been clearly associated with the presence of a large PFO. But also migraine with aura, a history of cryptogenic stroke, and a history of PFO or ASD in a first-degree relative. But they're kind of uncommon things, those last ones. Well, migraine with aura is not so uncommon, but certainly this is the big one, the history of decompression illness with those 4 manifestations. So that's who we should screen, and I've made this point. Not musculoskeletal, not minor neurological events. But this is the group that is most problematic. What about the person, and I'll bet you 50% of the people in this room will have had this experience, right? You're sitting in your office and some diver comes in and says, I've been reading on the internet and I've read that PFO is really important, I want to be tested. What do you do with them? Well, the answer is you can't really just tell them to, get out. But that's polite. Well, you can. But I facilitate this, but I do not do it ever without counselling them first about what they're getting into. So, this is what I say. If you have this test, there's a 30% chance it'll be positive. And then you're going to have some tricky decisions to make. A positive test doesn't mean you will suffer decompression sickness without having it repaired. Indeed, small lesions are probably meaningless, and the best data we have from that with this paper by Torti, published in European Heart in 2004, and they calculated the risk of a major neurological decompression illness event per 10,000 dives, and PFO grade, so no PFO, grade 1, which is a couple of bubbles across the PFO with provocation. Grade 3 PFO is spontaneous shunting of a large number of bubbles without any provocation, and grade 2 is somewhere in between. And you can see that a grade 3 PFO definitely represents an increased risk, but a grade 1 doesn't, and a grade 2 is non-significant. I mean, there's a signal there, it's non-significant, but it probably is, you're getting into the zone where there's probably a bit of a range within that grade 2 classification. So big PFOs are important, but small ones aren't. So that risk doesn't justify screening. We've already made that point. Now here's the thing, this drives me mad, right? And I try and impress this on the divers. A negative test does not mean that you're resistant to decompression sickness, because a lot of them seem to think it does. You know, you see this on the internet forums. Oh, I had a PFO test, so it was negative, so I'm off to 100 metres tomorrow, and I probably won't decompress much because, you know, I'm resistant. And the other one that really irritates me is this. A PFO found after decompression sickness does not mean necessarily that the PFO caused the problem. And this is one that the divers latch onto because they love to blame their decompression sickness on something. So they get decompression sickness, they have a PFO test and it's positive. So next thing they're saying online, oh yes, well, it wasn't my fault, I've got a PFO. And that drives me mad because the implication is that if they have the PFO fixed, then everything's going to be fine. If your test is positive, you've got three options. You can give up diving, you can modify your diving practice. If it's when I say positive, if it reveals a significant PFO, like a large spontaneously shunting PFO. You give up diving, modify your diving practice, or to try and reduce venous bubble formation, because as you know, we think it's venous bubbles getting into the arterial side that results in a PFO being significant. Or you can have the lesion repaired. But if you think about it, if you're not really seriously considering one of those options, what's the point in having the test? Not much point in having a PFO test if you're not going to do one of those. And I make that point to them as well. So as you know, a PFO repair is no longer open heart surgery. There's a transvenous catheter that gets put through into the right atrium, and then they insert the catheter through the PFO, and they get this kind of little mushroom thing that opens up on either side of the atrial septum and seals the PFO. You need to be on a potent antiplatelet agent for 6 months after they do this. It's interesting, there's been this assumption that putting an Amplatzer device in place will reduce, so closing the PFO will reduce your incidence of decompression sickness, and because it'll close the PFO and stop these venous bubbles getting onto the arterial side. It is fascinating that exactly the same logic was used to promote the use of these devices in people who've had cryptogenic stroke. Now, I'm going to acknowledge right now that there are potential criticisms of these studies, but this is a paper published in 2013 that editorialized 3 major trials that have been published since 2012 of PFO closure. These are randomized trials for prevention of cryptogenic stroke. And in every single one of them was the MIST trial, the closure trial, I forget what the other one was. But in not one of those studies did PFO closure reduce the risk of cryptogenic stroke. And in fact, putting one of those devices in was associated with a 3-fold increase in the incidence of new atrial fibrillation. It's not a benign, it's not necessarily a benign process. Now, if Peter Wilmshurst was here, he'd say, that doesn't happen in my patients, and that might be true, because he's done this, he's been one of the first to ever do it, and he continues to do it, he's very experienced. But there's risks. So decompression illness might not be the same as this, but it is a salient lesson. What seems sensible doesn't always work out in practice. Closing PFOs has been shown to reduce arterial bubbles in divers following dry chamber dives, not surprising. And this paper is the only one so far that has pointed to the fact that closing a PFO might reduce decompression sickness. So what they did was they took 104 divers with neurological decompression sickness and they tested them for PFOs. I think these are Swiss guys, aren't they? Yeah. Yeah. 65 were positive. So not all of them were positive. That's an important point. But 65 were positive. And of them, this is not a randomized study. These divers self-selected into these groups. 26 got closed, 39 didn't, and they were followed over their diving careers over the following 5 years. They all got closed because they wanted to keep diving. These guys did a mean of 295 dives. These guys, the no closure divers, did a mean of 175 dives. And the neurological decompression illness rate in the people that got closed was half a case per 10,000 dives. And the rate in the non-closure group was 35 per 10,000 dives. And you'd look at that and you go, whoa, that's pretty convincing evidence. But those numbers were based on 5 events. 1 in the closure group and 4 in the no-closure group. So it's extrapolation of very small numbers into large calculations, which, I mean, yeah. So it looks impressive, but I mean, it's an indication. I'm not rubbishing the study, don't get me wrong. I think it's great. It's fantastic they did this, but it's not definitive evidence. It's a signal that closing a PFO may well reduce decompression sickness. It makes sense that it would, but this is the evidence we've got at the moment. Just to point out that there are risks in having a PFO repair, and you've got to balance that against continuing to dive with a grade 3 PFO. We won't go through this now. You'll have these slides. It's a risk versus benefit decision. Yeah. This is another study about long-term risk. One of the points that often gets made is we haven't been putting these things in for long. I'm about to finish, CJ. And we haven't been putting these things in for very long. And who knows what is going to happen when someone's had one in for 30 years. But this was a study published in Heart in 2008. 10% of patients with a repaired PFO get new aortic regurgitation, just mild. And I think it's because the scarring associated with the PFO repair device pulls slightly on, I think it's the non-coronary cusp of the aortic valve. I can't quite remember. But anyway, they get a little bit of AR. But, I mean, that would make me nervous, I must say. So I think the easiest decisions relate to large PFOs found after one of those 4 forms of decompression sickness. Someone who wants to continue diving, I'd be happy for them to go and get repaired, but it doesn't mean it won't happen again. It doesn't. And the trickiest situation is finding a PFO in one of these randomly screened people who come in and say, I want a PFO test. And the risk of repair versus benefit in that setting is really hard to assess. And I'm guided by size. I mean, if it's a big spontaneously shunting PFO, they want to keep diving. Having it repaired is probably reasonable, but a small one, I usually try and talk them into managing it in different ways. And that's where I'm at with PFOs. So, that's it. So now we enter the phase where the New Zealander gets shredded. Yeah, oh, right. I'm not sure how you want to manage this discussion, and I'm happy to be guided by Jack and Franz, but what I've got here is I've just put up these things in the same order I had them, and like one thing we could say is, look at that list. Do you think those screening questionnaires are the right ones? Have you got any ideas? I mean, this will kind of get recorded, I guess, but does anyone want to make a comment on that and go through each one of them? I mean, does that seem like a... Jack? Or is there some bit you want to focus on?
I don't think we need to go into too much detail, other than to say that I don't think our screening questionnaire is adequate at the moment. I think adding something like this would add great value. So I'd rather first let us talk conceptually about these things rather than getting stuck in the detail.
Yeah, sure.
You know, I don't know whether you agree with
Could I make some just impressional comments? Something that struck me, Simon, was that what you were able to show from the DAN study is that the incidence of decompression illness, which is presumed to be between 1 and 4 per 10,000, now is approaching the cardiac death incidence. I mean, 1.4 per 10,000 is 16 per 100,000.
Yeah.
So the annual DCI rate and the annual death rate are actually closer than we thought. Not across the broad range of diving,
Yeah.
but certainly, you know, they're similar in kind, And that's different to what I previously had in my head. I had sort of a 1 per 100,000 death, 1 to 4 per 10,000 ECI.
Just remember, those are per 100,000 participants, not dives.
Yes, but it's per year.
Yeah, that's right. Yeah.
So in that sense, it's similar. The second thing was that just conceptually, we would need to stratify the fitness to dive attitude, the occupational health attitude, and the overall wellness attitude. And as he was speaking, the three brackets I thought that might help organize our thoughts were how we understand the liability issue. I'll explain what I mean under that. The legality issue and the life expectancy issue. Because under the liability, there's the buddy liability, there's the dive operation liability, there's the instructor liability, there's the insurance and the emergency health services that will be called upon. Those all become liable depending on how well we address this issue. Is everybody tracking just conceptually? So there's a liability component. Then there's the legality aspect, which could start with the Consumer Protection Act in South Africa, and then ultimately include the various occupational health and safety, mine health and safety, and other acts. And then finally, there's the life expectancy issue, which would have some actuarial implications. In other words, the person's life insurance, etc., etc. And then the social life expectancy. Do they want to support their family, and what are the other areas? So I thought, just in thinking around this, maybe that would organize some of our thoughts. And then the last comment was that we need to separate the prediction of cardiac death from our assessment of aerobic fitness. And I think previously we've tended to lump those together. And a stress test can be done without reaching 80% maximal heart rate. It can be done without really calibrating the aerobic fitness threshold. So anyway, those were just some thoughts. The incidence is maybe higher than we thought. We've got three frameworks in which we might want to think about it, and we should address the aerobic fitness component and the prediction of cardiac death component, realizing that our screening test that we're using now may or may not achieve those outcomes. Okay, so that's just into the mix.
It's a heady mix, Franz. It's how to organise those. If you want to discuss it along those lines, how it gets discussed over the next half an hour.
Back to Jack's praxis, looking at the screening questions. But I think in terms of this position statement and the ultimate decisions before.
I sense, as an outsider looking in, I sense a certain schizophrenia amongst occupational physicians in South Africa. Well, and it's not. It's imposed, almost imposed on you. It sounds like by regulation and expectation about what your role is, what your role is in this setting. Because if your role is just to decide whether that diver is going to stay healthy for the next year, then a lot of the logic of what I said applies. But if your role is to be more holistic, which is bringing in some of the life expectancy and the liability thing, I don't know. I'm always a bit wary of that. I think it's the tail wagging the dog to some extent. I mean, if you look after the diver, you should look after the liability. But if you're looking at the sort of diver's holistic health and projecting that forward into the future, that definitely would change. You're behaving more like a family practitioner, and that would change the way you would approach the assessment and management of cardiac risk factors, in my view. And I guess I'm an outsider in that respect, looking in. So
Just on the liability thing, could I just challenge that in the sense of the reason why we're concerned about a scuba diving fatality versus a lawnmower fatality is because the implications on other people, not
I understand that.
Financial, but also the body.
Yeah.
So there is that component of the liability.
I understand.
We wouldn't care.
No, I understand that. I do get that, but
how to manage it.
Jack.
Yeah, I do think that the context and the schizophrenia needs needs to be explained in that, because...
I wasn't meaning to be insulting.
No.
It's been used before.
No.
Right. Oh, has it? No. Okay.
No, not at all. Because I think we actually mix the two.
Yes.
So legally, you're right, this is what's being imposed on us. So we are required to do certain tests on behalf of the employer. The responsibility is actually not ours.
Yeah.
It's an employer responsibility. And then in terms of what in South Africa is criminal law, that responsibility is imposed on us. So we've got criminal liability included in there, in this assessment. Furthermore, there's another act, the Employment Equity Act, which literally states, it says that medical testing of an employee is prohibited unless the tests that you do are linked to the inherent requirements of the job. So if you do a blood pressure test on an employee and it's got nothing to do with the inherent requirements, that if a person's got a high blood pressure, you're not going to make him unfit to do that job, then you're not allowed to do it.
Yeah.
Because you're doing it on behalf of the employer. So you need to distinguish between being an occupational medicine practitioner on behalf of the employer, where there's a doctor-employer relationship, and being a GP where there's a doctor-patient relationship.
Yep.
So when you see a diver or a commercial diving medical, there's I almost want to say there's no doctor-patient relationship existing. The relationship is between the doctor and the employer. You give him a certificate that is not for the diver. The certificate goes to the employer saying this employee is fit for the job.
I understand that.
That's the difficulty. So it restricts on what we do. And in fact, we had a discussion 2 weeks ago with a legal expert came and speak to us, saying that all our medical records actually belongs to the employer. We keep it on his behalf. And if you include things like blood pressure, etc., you actually have to have 2 separate medical files. That's literally what he said.
Wow.
Because if the employer says, I want my medical records, I'm now appointing a different occupational medicine practitioner, then you need to hand over all those medical files to the following person, because the employer must keep the records for 40 years.
But Jack, if you wanted to measure someone's blood pressure as a way of plugging them into a risk predictor like that, surely...
Then it's an inherent requirement.
Okay, all right, so that would be okay.
Absolutely.
Yeah, okay.
But if any examination you do that you say, well, this is a good idea, it's good for the person, it's for his long-term health, the employer would say, no, I need to certify that it's fit for the next 1 year. I'm not interested in 10-year risk, I'm interested in 1 year risk. And that's the difficulty.
Yeah, I get that. Yeah, I can see that. It's a big issue here. Jonathan's been waiting to say something down the back there.
No, I'm also waiting for him to tell us about the case.
Yeah, a couple of observations.
Can you speak up, Jonathan, nice and loud?
Yeah, sure. A few observations. I mean, the one practical aspect is that I see probably several hundred divers a year. And for a number of those, there are key complications that make what Jack spoke about practically quite difficult. One is there are those divers who are sent by a company, probably I would say 50%. The other 50% are freelancers. And they say, who are you working for right now? Now I'm waiting on an email. So they don't have a specified employer.
Yeah.
So for those in my own practice where there's a specified employer, there will be a company account with subfolders for each employee where the diving records are kept in that folder. Some of those individuals will see me as a general practitioner as well.
Yeah.
They'll say, Doc, you're the only doctor I see every year. Can you check my prostate? I'm over 50.
Yeah.
PSA, which obviously has no relevance to diving medical. And I'll then put that in a separate folder, which has got a different identification, different record completely. It is not important to diving.
Yeah.
So that's easy in those cases where there is a sense an employer who sends them and they have a private folder. There are those that simply are freelancers. And that's more complicated because they're not sent by anyone.
Yeah.
They take it in a single record, which in a sense is involved. So that's one practical challenge. random observations that I just wanted to raise as well. I think one relevant thing in our South African context is a relatively high incidence of familial hypercholesterolemia, which does make, in certain cases, cardiac disease relevant at a lower age.
Sure.
In those patients.
Yep.
So I included in my screening a total cholesterol test, which, if you're lucky, is faster than half. It's not faster than the blood. If they come in with a cholesterol in excess of 8, then obviously that has implications in terms of what's really on. So that's one thing just to observe. Another just anecdotal observation is I saw such a patient with a high cholesterol, advised him to have it managed. He chose not to go and seek help and go on statins and so on. And in fact, did a stress ECG as part of my evaluation. The patient was 42 years of age, he had a cholesterol of 7.8, asked him to see his GP. 3 weeks later, dropped dead in the journal of myocardial infarction.
Yeah.
About 10 days after resaturation. So,
Yeah, well, no, yeah. So, allow me to say, Jonathan, that's a great story. One can always come up with the anecdote to demonstrate why a rule you're trying to create won't work, but unfortunately, you can't base policy on those kind of stories.
But I mean, in fact, I was going to say to reinforce that is I think I still think I would not have done any more investigation.
No, and you'd be entirely, my point I guess is you'd be entirely justified in it, and you can't be blamed for that. Your cholesterol thing and the observation about the prevalence in South Africa is fine, and that's why I think in the occupational medicine setting we have that advantage. We can do those things and plug them into a risk score like this, and that might have led you in that setting, depending on the other parameters, to do a stress test or not. But yeah. No. In an attempt to get something solid out of this, and in an attempt to winkle what I think is an oddball practice out of the care map, can I ask, is there anyone in here who wants to debate this with me? Because you do this, right?
For the initial, the very, very first time you see it, that's
Yeah.
what you mean by baseline.
Yeah. Is there anyone who wants to debate that? I mean, can we come... Would it...
Do we potentially agree, or do we all uniformly disagree?
Yeah.
I think we all uniformly disagree.
We do.
I think so.
Do we? Does anyone disagree with Franz's uniform disagreement?
Is there anybody that doesn't do a baseline stress ECG in a commercial diet?
Is the question doesn't or don't think
Initial
it's
medical.
necessary?
Yeah, so the question I'm asking, is there anyone who thinks that it is a good idea to do a baseline stress ECG on a candidate less than 45 years old who's got no to everything on their screening questionnaire?
It's mainly done for future comparison of what's...
But what are you going to compare? What
Observation what you have to do legally every year. So at least you can look at that. You can start coming to you. That's also another practical thing. Because these guys go whether they feel they should be going, whether it's cheapest. So at least you've got something to compare with it in that state. It's not of much value, long-term protection-wise, but if it's something to work.
But if the first test is negative and the second test is positive, what's the value of the comparison?
Yeah, it's really an entrenched practice pattern.
It's an entrenched practice pattern.
And it's rightfully challenged by you, Simon, but I don't think anybody has the gonadal fortitude to depart from that entry level. You know.
This is like, here's this big tail wagging the dog. I mean, we're experts. We're the people who know. I mean, why can't that be changed? Yeah. The EDTC is. This is what they say. Well, I would say they're wrong too. Yeah. I think if that's what EDTC say, I'd say EDTC are wrong. There's nothing in the literature or data that would suggest that that's sensible.
Exactly on that.
Yeah. Oh, they agree with me. Oh, okay. Sorry. They're right then. Yeah, they're right then. Yeah. Sorry, Jörg, did you?
May I say something about this from the EDTC side? Of course, you have to see that EDTC tries to get a standard in a consensus of European countries, and nowadays with also with overseas participation. But that is not the real. That is not a gold standard, because it is a consensus. It's not based on evidence and so on. This workshop was elaborating an actual consensus based on evidence they have, and I think this is a higher value. We are actually revising the standards, and I think these things will go into our revision. So maybe in 1 or 2 years, when we finish going into the second edition of the book, it will be a little bit different. So things change. What I want to say from my personal point of view is that you are completely right proposing this here. From my point of view, I agree with you. However, doing the medicals for professional divers, I do a stress test in order to know their work capacity. And you can do that in a sub-maximal way or in a maximal way. That depends on your personal preference. But just to add an ECG is not any effort for me. It is our health and safety authorities want it, so I do it. I'm not convinced that it helps anything, but I do the exercise anyhow. It takes me not 1 minute more time.
So, Jörg, that's a great point. If you want to use it as a functional capacity evaluation, I won't argue that it has no value, because it does. Coming back to your thing, Franz.
May I add something? Sorry.
Yeah.
The good thing doing this every year, or it's not every year, we do it in below 40 years, we do it every 5 years, and then we do it every 2 years. In doing this repetitively is also to monitor the patient, not only for me as a doctor, but also for the diver himself. When you see his capacity going down, and at the same time the weight is going up and other things, then you have an argument to tell him what he has to do to keep his fitness.
No, I'm not going to argue with that. I'm thinking of this as a screen for cardiac disease. And coming back to can I just come back to your point, Franz, about the sort of the more holistic approach, and your point about having something to compare. If that's what you really want to do, have something to compare, and have this holistic approach where you're managing the diver's health over a long period of time, why don't you do this? Why don't you do one of these tests? Then you've really got something to compare, because you can see progression.
From a practical point of view, a screening, the resting ECG for long QT would be done anyway.
Yes, of course.
And once the electrodes are on, Simon, you put them on the bike. I'm not saying that that's right. I'm not saying it's defensible. I'm just saying that that's sort of become entrenched.
Right.
So and I'm not even defending it. I'm just saying that's the state we're in from a practical point of view. I think there's the capacity within the group to argue an opt-out scenario, doing stress testing, if we come up with an improved screening questionnaire up to the point of collective comfort, or at least critical mass. So I think that we can go that way, but in practice at the moment, once you snap the electrodes on, you've done the resting, you move to the bike.
Yeah, it's easy to say. It's a lot easier to do a baseline 12 lead and not exercise them than it is to do a proper Bruce protocol. Is quite
well, it's usually an exercise bike, 80% of maximal predicted heart rate. Baseline stress 1, 3, 5 minutes. That's sort of been the norm.
Right. Okay.
So that's the norm that's challenging, and part of it's cultural, I'll agree. Part of it's practical, even financial, and part of it's just the pucker factor.
Yeah.
Do we change?
I'm taking a little list of these things, Franz. So there's gonadal fortitude and pucker factor.
They are just but very simple.
I like it. It's one of the benefits of coming to all these different meetings. You see, I'm going to be, when I go to the BHA next weekend, I'm going to be talking about pucker factor and gonadal fortitude. It's going to be great. They'll think I'm really clever.
Can you do that sort of test on a diver, commercially, practically?
Yeah.
There's a financial implication there as well. You try to go visit the home to have something done in addition to it doesn't require. There's no way. It's actually not going to come back. You could use that this day.
I understand that.
So it's very difficult in practice.
Yeah, I understand that. But if you are going to tell yourself that you're really making a valid comparison, the exercise stress test is not the way to go. If you want to track the development of coronary disease over time, you need to use something else. It needs to be something.
He's only there for 1 year to see that he's fit when he's had to look after his lifestyle. Not normally.
Okay, yeah.
Just coming back to the questionnaire, the age group 45.
Yes.
Is that relevant? Because then you would miss maybe the guy that Jonathan talked about.
Yeah.
And if we change that to 35, does it make more sense? Or take the age out of the whole equation?
Well, there is a question in here that covers the... To your current knowledge, has a close blood relative less than 50 suffered disability or premature death due to heart disease? So there is a family history component that backs that question up. But yes, you can debate the 45. I wouldn't have a...
If you're then 35 and you've got a cholesterol of 50, you're just not going to read further.
Negative other factors.
Yeah. So any of positive to any of these would probably result in you. So if this was negative because you're not older than 45, but this was positive, then that would be a reason to send them for some kind of investigation.
Bearing in mind that many South Africans don't know who their relatives are.
Another cultural context. No, fair enough. Yeah.
So the question was, if you take out the age completely and just keep the sentence as it is it not?
Look, I'll be honest. Trust me when I tell you, I'm not putting this up as the gold standard. That you can. I've put this up as a straw man that you guys can have a crack at, and yes. Oh, sorry, I'll come.
Sports medicine, change in sudden cardiac death, sort of 35. So before 35, it's not ischemic, and after 35, it might be more.
That's where the AHA have drawn their line in the sand. Yeah.
If our objective is to reduce cardiovascular death, and if we see divers, commercial divers anyway, on a yearly basis, and if an effort test gives us some prediction of the risk in the next year, then surely it's logical to do an effort test on everybody, because you're going to be able to stop that guy from diving, and you're going to potentially take, I mean, there's the numbers to treat financial economic consideration, but at least we're going to remove a potential death from the pool.
Well, that's a philosophical question that only you can address. It's the whole, if you get someone here who's an expert in the science of testing, they would argue strongly against what you just said, because they would say that it's not sensible to do tests that have no sensitivity in the defined context. So if you've got someone who doesn't meet any of these risk factors and you do a test on them, you're not going to get a positive result very often, and so you're wasting a whole lot of money doing the test. Your argument is, well, let's just waste the money and do the test anyway, because we may pick up a few, and it's kind of what Jonathan was implying with his story, sort of. And I know you weren't really, but So I know, it's a philosophical question, and I can understand your position. Let's be really safe, but I think it's low yield. It's very low yield. There may be better ways to spend that money and effort. I don't know.
I think there's another patient that Jonathan needs to tell us about. The one that came back with a positive test, stress test, and went for angio.
Yes, that's the other problem. Yes, good point, Jack. So they have false positives.
Another unfortunate case.
Yeah.
Who, in fact, met criteria. So he was over 45.
Yeah.
Nevertheless, had a stress ECG, positive on criteria, about 2.5 millimeters mesh decompression, natural means. Saw a cardiologist and said, let's do an angio. Did an angio, managed to rupture his right coronary artery with a catheter. Ended up with open coronary bypass.
Yeah, there you go. Yeah. I mean, again, an anecdote, just because it happens to defend my stance, I'm going to run with that. No, but seriously, so that is one of the other problems, is that there is a false positive rate. Obviously, it's not a particularly specific test. Yeah,
it's about 50%.
Yeah, it's quite high. Yeah.
Just from a practical baseline point of view, the practice, for the most part, has been an initial stress, and then at 25, 30, 35, 40, and after that annually. That's what we've had for the most part previously. What we amongst ourselves at the Barometrical facility have considered is, if these sort of questionnaires yield low risk, to opt out. So that the expectation from the diver side, he comes with his tackies, he comes with a wallet laden for the stress ECG, but if he does not meet the requirements to do it, then there's an opt-out possibility. So that's just from a practical point of view, how we've started the process to wean ourselves off the stress ECG. I'm just saying that's what we did, and I would like to just introduce that for consideration.
We're going to have to wind this up, aren't we, CJ? So, look, I've really enjoyed this discussion. I hope I haven't been too provocative.
That's why we wanted you.
Yeah, okay, all right, fair enough.
So you can catalyse it for us.
No, it's been interesting. But anyway, look, there's some straw man stuff in that paper. You guys can have a look at it and work with it. And I'd be interested in hearing how things evolve.
So can I just get an indication? Is there anyone that doesn't agree that we need to look at this and revise this?
Well, I think the question is whether we want to practice evidence-based medicine or not.
Yeah.
Bearing in mind that in many cases we practice in a data vacuum, and we need to know where those vacuums are.
But actually not here.
But that is not a data vacuum. So if the evidence is there, then the other thing that I think also comes in is practicality. Because if you look at some of those screening tests, and the two colleagues sitting right next to me, it's not available there. And to say that now I need to send a diver for medical examination, but he has to travel 1,000 kilometers to get his test, is also a problem. So there are some practicalities where we need to say, right, this is the guidance, but there is perhaps a second alternative or a second way of doing it. My sense is that we're trying to make up with the stress ECG what we've missed in having a proper questionnaire. We had one question of do you suffer any cardiac problems? That was it. If you get the right questions and you stratify risk by looking at age, smoking, diabetes, and all those other things, I think our sensitivity would approximate the sensitivity of a stress ECG very closely. And the stress ECG then becomes a confirmation of what we find in the questionnaire in any case. That's my sense.
Yes. And the intellectual and emotional thing we need to resolve is, if a person were to die of a cardiac event, would we be reconciled with the fact that he didn't have a recent stress ECG?
And I think that's what we need to move towards, because the reason why we don't want to move away from it is that if your diver dies, then people are going to say, well, you didn't do a stress ECG. You should have done it every 5 years. You should have done it every year.
Those diving fatalities, are they not mostly in the recreational group?
Yes, that's exclusively a recreational group.
So then you might as well have a joggers alert network.
Well, that's where the liability and the legality aspect comes in.
Because they get down.
So there's in the last 10 years only been one cardiac-related death in commercial divers in our region.
The surveillance thing comes in.
So we don't call each other negligent.
Absolutely.
So I think we as a SAUMA executive committee is going to draw up a position statement and say, well, this is our position. Based on the evidence, I think and then we're going to present this to the members and take it from there. But just know that these are the discussions that we are having. We have to look at the evidence. We can't continue practicing.
It's always been my sense, if you look after the medical practice, then everything else will look after itself.
Yeah.
If it's defendable medical practice based on the best medical science we have, then everything else looks after itself. Sorry, Lawrence, you...
Can I ask a question?
No.
We have an official design, like in aviation medicine, a questionnaire which will incorporate best practice medicine, not only for this cardiac issue, but we should also get questions done for the asthmatic issue.
Yeah.
Psychological issues we spoke about yesterday.
Yes.
It's not in there.
It would be a great project for an occupational medicine trainee.
Long pages. When can we expect this document?
Well, seeing that somebody has just volunteered to come on the executive committee, thank you, Lawrence. You can tell us when to expect. No, I mean we have to do it. I mean that's why we had this conference. I mean we touched on a lot of issues that are relevant now. I mean the psychological issues are becoming more and more relevant.
Yeah, it's good stuff.
It's not in there. The cardiovascular things, you know.
This is not different of treating any patient, whether he's a dialer or not.
Yes.
Yeah, I agree.
So that's issue. That's why your American Heart Association, all the recommendations for it.
Yeah.
But in practice, we have what we call a medical executive report. It's a healthy chap paid by his employer, the executive Anglo-American, come to see you once a year for this list of tests and stress issues. And that's where part of our problem lies.
Yeah, I can see that.
Actually in our members, our patients,
Yeah,
that they want that test.
I can see that. Well,
That's where the
But
culture
the
needs to
figures
change.
are exactly the same, the indications are the same as in general,
is anyone else? Yeah.
whether you're a dialer or not.
Yeah, I agree. Well, thanks everyone. That was awesome.